بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك أنت العليم الحكيم. My topic today is about differential diagnosis of the fat-containing lesions in the peritoneal cavity. The common causes of the fat-containing lesion in the peritoneal cavity include sclerosing mesenteritis, omental infarction, epiploic appendagitis, fibrofatty mesenteric, proliferation, intussusception, and dermoid. And here some of the helpful clues for the common diagnosis. Many of these lesions have a characteristic imaging and clinical representation. First of them, it is sclerosing mesenteritis. It causes abdominal pain, chronic in nature, usually involve the jejunal mesentery and has thin capsule and small mesenteric lymph nodes, and it is envelop the superior mesenteric vessels. Here you see patient with sclerosing meningitis in axial CT scan, and you see the density of the fat in the mesentery around the jejunal lobes is increased with fatty infiltration with the strands, and it is with small lymph nodes, and it is the mesenteric vessels causing the heterogeneous infiltration of the mesenteric fat without involving of the mesenteric vessels. Omental infarction, it causes acute abdominal pain, primary from almost always adjacent to the ascending colon. If it is secondary, it is near the site of surgery or inflammation. And it is size, it is larger than epiploic appendagitis, and it is around 5 to 10 centimeter. As we see here in the axial CT scan, omental infarction, oval mass lesion with fat density adjacent to the ascending colon in child patient with focal tenderness. No surgery needed for this mass. Epiploic appendagitis causes acute abdominal pain and usually adjacent to the descending or sigmoid colon. It can also affect any part of the colon and is present on CT scan as oval shaped fatty mass adjacent to the colon, measuring about 2 to 4 centimeter in diameter with thin hyperdense rim and central dot of a thrombosed vessel. As we see here in the axial CT scan adjacent to the descending colon, oval-shaped fatty mass lesion with hyperdense sclerotic rim and surrounding by inflammatory stranding changes associated with the thickening of the overlying peritoneal cavity. No surgery needed for this mass lesion. Another example of epiploic appendagitis in another patient. Another patient with epiploic appendagitis. Fibrofatty mesenteric proliferation. It is common in long-standing Crohn's disease, and you should check for radiological signs and medical history of Crohn's disease. As we see here, this patient with a Crohn's disease with thickened terminal ileum and associated with surrounding proliferation of the fat adjacent to it. Intussusception: mesenteric fat is drawn into the intussusception along with the bowel intussusceptum, appear as a concentric of fat density within the intussusception in cross-section imaging. As we see here, patient with intussusception on this axial CT scan, mass lesion in the right lower quadrant with concentric fat seen in the intussuscepted mesentery of the terminal ileum. Dermoid can be fat with soft tissue and calcification, as we see here, much dermoid cyst with fat density of the left ovary. Less common causes, we have retroperitoneal sarcoma or liposarcoma can simulate intraperitoneal lesion, metastatic malignant teratoma, cystic fibrosis of the pancreas, lipoma of the GIT tract, and lipomatous infiltration of the ileocecal valve. And we see some examples here. Cystic fibrosis of the pancreas, and we see lipomatous pseudohypertrophy of the pancreas, as in this patient, with the pancreas is completely replaced by fat in patient with cystic fibrosis. Lipoma of the GI tract may arise in the stomach, small bowel, colon, and it is fat density spherical mass lesion. As we see here, oval-shaped mass in the stomach discovered incidentally in old woman, and this woman has also old calcification in the spleen representing old head infection. Another lipoma noted on the anterobiliary part of the stomach, and another patient with lipoma in the interim of the stomach. Here, this is a small mass lesion in the duodenum, and it is fat density. It is lipoma. Lipomatous infiltration of the ileocecal valve may appear as intraluminal fatty mass, as in this patient, with lipomatosis of the terminal ileum, and it is extended to the ileocecal valve. And this patient has also parapelvic cyst on the left side of the kidney. This patient has retroperitoneal liposarcoma, large mass of fat and soft tissue density simulating intraperitoneal mass lesion. Thank you for listening and have a good day. Hoping to see you soon.